It's my very great pleasure to start the session today, and I'll be talking about the Sussex Integrated Care System heart failure pathway, in addition to giving you a taster of what's going to be coming for the rest of the morning. So as I say, I'll be starting. For those of you who don't know me, my name's Alison Warren. I'm a consultant pharmacist in cardiology based in Brighton and Hove, and I work at the Acute Trust and within the ICS. And I co-chair this group with Sarah Young, who you'll see later on the call, who's our nurse consultant for cardiology in Brighton. And the agenda has been set up by our multidisciplinary group, and I hope you'll find it really interesting. So we will be having a clinical update around the Esc Guidelines and beyond. Jen will be talking to us about the heart failure dashboard, and then we'll give you a little break. And then after the break, we'll be doing some networking sessions. You will be moved into a breakout room with a facilitator, and we'll be getting some conversations going around the things that are important to you. And then we'll have an update on the new Southeast Cardiac Clinical Networks. And then we'll just take a little bit of time to reflect on what we've heard this morning, what we've talked about this morning, and how we might move forward across Kent, Surrey and Sussex to improve the working of for yourselves and also the care of heart failure for our patients. So the aims of today are really to give us some time to take a little breather away from the pressures of the day job and reflect on the services that we both provide or commission for heart failure patients, to give you an update on recent changes in clinical practice and to think about how these might change your practice, to increase the awareness of the networks. As I say, these are in very early stages, and you'll be hearing from Vicky Parish more about that, and to provide you an opportunity to network with your colleagues across the patch and across areas where perhaps you don't work, and hear how things work in another area, to support each other, and then to take a collaborative view on the key priorities for heart failure services for patients in the Kent, Surrey and Sussex patch, which will inform our work plan. And we'll be also asking if you would like to be more involved with the project group and talking about how that might be able to happen. So I thought it might be nice just to take a little step back. Many of you will have been coming to the collaborative events for a number of years. As you may remember, we started out as the Enhancing Quality programme, but for the last sort of 3 or 4 years, we've been supported by the British Heart Foundation, and the current committee took over the running of the events in 2018. So our first event focused on the NICE guidelines for heart failure, which had just been published at that time. And the second event in 2019, we took forward some of the work that fell out of the networking around there and some of the key themes, some of the quality improvement projects that had gone along aside that, as well as some clinical updates and some look at the data. And of course, we had an event planned for 2020, but this nasty little virus thing with all these spikes got in the way, and we had to cancel the event. We did run some webinars, which I know many of you did join us for, to try and bring teams together, because it was an incredibly difficult time for everyone. And we focused on some of the challenges of delivering care to our patients during the peak of the first wave of the pandemic, and talked about new ways of working and what was working well and what the challenges were. From the previous webinars and meetings we've had, the things that you've told us are helpful, that you like the meetings because they give you good peer support. You like the networking opportunities, so we really hope that you will engage with the breakout sessions, because that is a networking opportunity to discuss your ideas with other teams and other members of the team. You like to see examples of what has worked well or challenges, and we would ask if you have something that you think you've been involved in that is an example of good practice or an innovation, or something where things have been difficult and you've had to work around a new way to deliver or to develop the service, then we would love to hear from you and ask you to share that with the collaborative. And of course, the clinical updates are always useful, and Dr. Coombs will have lots to share with you on what's been happening in the clinical field. There are lots of policy documents and statements out there that can help. So if you want to have a look at any of these, I've just really highlighted a few of them. We can't go into them in massive amount of detail, but I'm sure these will resonate with you all in your teams. So this is from the Heart Failure Policy Network, and this is sort of the 6 areas of urgency which have been affected by COVID, and this is about how our teams need to be reinstated. But I think we all agree that the teams are under a lot of pressure with caseload. And it's not only about reinstating our specialist teams, but it's making sure we have an adequate workforce that's fit for purpose. We need to make sure that people are diagnosed in a timely way, and we need to be able to maximise all the models of care that we have, which may be the more traditional models or more remote models, and we'll talk more about digital technology in our breakout sessions. And of course, we need to support each other and to support all professionals working in the field. Many of you will have been working throughout the pandemic with heart failure patients, and I'm sure you will have realised this from your own caseloads, that our patients are extremely high risk. Patients with heart failure admitted to hospital with COVID have a very poor prognosis. Patients with heart failure hospitalised are at high risk for complications, and with nearly 1 in 4 dying during the hospitalisation if they are hospitalised for their heart failure with COVID. And here's just an example of a couple of the publications that go through that in some detail. In 2016, the Heart Failure Alliance produced a number of statements around good care of patients with heart failure, and they provided an update to this document using a traffic light system to look at the areas and whether progress had been made. And you may want to have a look at those key priorities and think about your own area of practice. Some of this is around things that you can influence on a local level, and some of these will be around things that would need to be influenced more at a political level. But for those of you that are in the commissioning field, it does actually highlight some of those areas where we need to look at the organisation of our services as well as the actual delivery on a day-to-day basis. The British Heart Foundation have published a couple of really useful documents in the last few months. This is the Heart Failure, A Blueprint for Change, and this is around trying to increase the focus and the priority on heart failure, reframing heart failure as a long-term condition. For many years, we know that heart failure has tended to get fairly sidelined in terms of the long-term conditions in primary care. Hypertension, atrial fibrillation, cholesterol management receiving much more focus. And so we do need to make some noise around heart failure and why it is so important to get good treatment in place for our patients. So this is around reframing it as a long-term condition, making more people aware of it, driving that change with data. And Jen will talk to you more about that later. And of course, leadership across the whole pathway. Many of you will belong to the British Society of Heart Failure, and you may have come across their F-word campaign. I think it's rather nice. So it's freedom from heart failure. So a lot of noise coming from the British Society of Heart Failure around awareness of heart failure, and this F-word campaign is around trying to encourage us to learn more about heart failure, to recognise symptoms such as fighting for breath, fatigue, and fluid build-up, so that there's better, more timely diagnosis and instigation of treatment. And this is probably the most recent publication that you may have come across, called The Untold Heartbreak. Now, this is not specific to heart failure, but it's around cardiology in general. And this is again produced by the British Heart Foundation with key recommendations ensuring appropriate funding and resources, clear leadership across the system, robust cardiovascular workforce, evaluating and sharing good practice, and supporting patients as partners in their care. Now, we don't actually have a patient representative presenting to us today, and you will remember that's something that we have done in the past. And that was because really with the agenda that we've got today, we really didn't feel that we could do complete justice to that, but it is something that we will look to do in our next collaborative event in terms of having more patient involvement in the event. A couple of slides just from the British Heart Foundation publication, just to highlight the involvement of patients in their publication and some of the key messages and things that patients are saying to us around the disruption to the patient pathway, people avoiding accessing care during the pandemic. Some of that's around changes in help-seeking behaviour. Some of that's around availability of cardiovascular services. Some of it's around changes in the way that care is delivered. And although some people like or don't dislike or perhaps even prefer some of our digital solutions to healthcare, there are some people that would prefer to have face-to-face contact and do not like the digital support. And of course, we know that there's been disruption to key programmes of work, such as the NHS Health Check, which was help the early identification of patients potentially with long-term conditions. And although this might not specifically be the heart failure patients, it may be more diabetes and heart failure. We're all very aware that many of our heart failure population come from the patients who have had previous diagnosis of those conditions. And of course, the patient view is really important. So a lot of our patients did shield, even though they may have done that out of choice rather than by request. And calls to the British Heart Foundation helpline show that access to care has continued to be an issue throughout the pandemic. Some of that's around the fear of COVID-19. Some of that's around patients' perceptions of being a burden. Some of it's around not knowing who to turn to. And people in the focus groups are very clear that they need to know who to go to for their personalised and professional guidance. And I'm sure you've all seen in the press around delayed diagnosis and reduced access to treatments. And this is true also for heart failure patients. We know that many of our team were redeployed in phases of the pandemic. We know that there was a considerable strain on the echo service, and the echo service is an area of difficulty in terms of workforce in general. And we know that people delayed or did not access care, and this may have reduced in a delay in the diagnosis of heart failure, and general feeling that we're starting to see a lot of those patients now, but in fact that they may be patients who have either deconditioned or new diagnosis who perhaps are presenting to us a bit later. So there's a lot of work to be done in heart failure, and we need to be able to look at how we run our services and work them as smartly as possible. There are some levers in primary care around the QOF requirements. These are a welcome introduction in that the QOF requirement for heart failure now has a requirement for a 12-month review. Okay, a nice guidance suggests that patients should be reviewed 6 monthly, but at least there is a requirement now in the QOF for a 12-monthly review in primary care. And in the new primary care network service, there will be some levers around the new requirements in 2022-23. So COVID was recognised as a high-risk area, and across the Sussex ICS we had got together a multidisciplinary group to try and highlight the importance of managing our heart failure patients well in terms of early diagnosis, instigating good treatment. This may prevent people decompensating or hospital admissions, and of course our hospitals have been under a large amount of pressure in terms of their capacity to take patients and manage conditions because of the COVID load. So we have now across Sussex a primary care pathway that covers diagnosis of new patients in primary care, the expected treatment pathway for patients with HFpEF and patients with HFrEF, and some documents that will help support management in primary care of patients who may be decompensating, including appropriate referral to the community heart failure teams, and some suggested review templates and advice for patients around symptom management in primary care. It is based on NICE, and you will realise from the talk that Dr. Coombs is going to come on in a minute for us that the NICE guidance came out in 2018, and of course there have been a number of developments in the management of heart failure in that time. The pathway that we developed in October last year had to be updated early this year to include the SGLT2 inhibitors, which I'm sure you will all be starting to use in your practice. And I won't steal your thunder, Steve, on this, but lots of really interesting data, both in the treatment of patients with heart failure with reduced ejection fraction and in fact in patients with CKD, and a place for patients to have the SGLT2 inhibitors added to their therapy.
Stop spoiling my talk, Warren. Stick to
I know. So that's why I'm going to say no more, Steve. And then I just thought I would highlight this. This is a document from the Heart Failure Policy Network of the EU. Now, I know we've had Brexit and we're not really part of EU anymore, but I just thought this was quite an interesting document that came out very recently, because actually this is not just a UK problem. When you look at the action statements in this document across the EU, they're the same. They resonate with everything that we're saying in our policy documents in the UK. So we need to be looking at effective strategies for patients. Despite its prevalence and impact, heart failure is often not seen as a healthcare priority. Exactly the same with things that we're saying, it translating into missed opportunities to reduce the economic and social burden of the syndrome, as well as to protect the health and the well-being of our patients. So I think there's some real key messages in all those documents, and if you're looking to make the case for why heart failure is important, I would refer you back to some of those documents to see what they're saying and to get the data. However, I'm going to stop at this point. I know the agenda said I was going to talk for another 10 minutes, but you'll be very pleased to know that I'm not. And in fact, I'm going to hand over to Dr. Coombs, because there's a lot for Dr. Coombs to cover in his session. It's with a great pleasure that we welcome Steve to come and talk to us. He's one of our heart failure consultants at the Sussex Cardiac Centre, and he is a wealth of knowledge around the whole spectrum of treatment of these patients. And thank you so much for taking the time to come and talk to us, Steve. I can't hear you. Are you talking?
I'm talking now. Let me change my settings. How about that? Can you hear me now?
That's better. Thank you.
Okay. Good morning, everybody. Thank you very much for the invitation to come and speak to you this morning. I'll put my slides up in a second. So as Alison's really nicely kind of introduced, the guidelines that we're working from, that I'll show you as part of my talk, are kind of increasingly becoming obsolete, particularly in the treatment of heart failure. And the new Esc Guidelines are much, much better, in my opinion, in terms of reflecting what I think a lot of us are probably already doing. And it's really nice to have the support from a major guideline that, the things that we've been using to treat our patients are the right things, and that is supported not only by evidence but also by recommendation from a major organisation like the ESC. So I'll just share my screen. So hopefully you can all now see that first slide. Someone let me know if that's not the case.
Yeah, that's good. That's good, Steve. Thank you.
Great, thank you. So apologies, I should have changed, out of date already. Should not say BSUH anymore. I need a new logo for the corner. And anyone who's been anywhere near the Royal Sussex site knows it doesn't look like this either. If you had a few cranes and quite a lot of scaffolding, that would be a better representation. But so what I'm going to do is go through the ESC guidelines. Now, as any of you who've looked at any major guideline will know, it can be a bit overwhelming. There's a slide set for the guidelines that you can download from the ESC website, but even that is 120 slides of content. There's a lot in there. So what I've tried to do is to focus mostly on what's changed rather than going through every single line of every guideline, and to focus on the really important things, in other words, things that carry a class 1 indication. And I've broken it up into 3 sections, again, just to help people get their head around it, which is the sort of diagnostic bit, the medical treatment bit, and then the other treatments, which includes devices and ICDs, CRT, valve disease, AF, kind of everything else, essentially, alongside, if you like, the primary medical treatment of heart failure. As I say, I'm going to focus on what's new, just to break up endless slides of guidelines. I've chucked in a few bits of evidence, just as a kind of reminder of why the guidelines look the way they do. And just a reminder of, how powerful some of that data is. And then I'm going to look at the end briefly at a couple of areas where a little bit on devices and a little bit on medical therapy, where we maybe can do more beyond the guidelines, and a couple of areas where I'm not sure the guidelines have quite got it right. So we'll do that at the end. This is my not rocket science slide that I like to use quite a lot. None of this is particularly difficult. I think you're going to see, hopefully, as I did when I looked through the guidelines, that what you're already doing is probably very good. And I think the guidelines have really cleaned up some of the recommendations. And in my opinion, the current ESC guidelines are now very much in line with what most progressive sort of modern heart failure teams are doing anyway, which is great. So a reminder of how the ESC, how they write their recommendations. They give a class 1, class 2 or class 3 recommendation. Class 1 is essentially a standard of care. Things that carry a class 1 recommendation should be done. Simple as that. Class 2 are things that can be done, that are generally considered safe to do and reasonable. And they divide that into 2A and 2B, where 2A is sort of a stronger indication. 2B is more of an option for patients, and maybe a little bit of controversy about, whether that's the right thing to do, something that perhaps may apply to some patients, but certainly not to all patients. And then class 3 are things that you should not do. So it's a bit of an odd way of writing it, a recommendation not to do something, but essentially class 3 means that actually there's evidence that generally shows that that's either harmful or ineffective, and that's not treatment that we should be offering, or not tests that we should be doing for that patient. In some areas of the guideline, they also then give the evidence base, A, B, or C, where essentially A is multiple trials, large randomized controlled trials, more than one, often a meta-analysis, large amounts of data. B is often one very convincing trial, which we, obviously applies to some of the treatments that we're currently offering, but maybe a lack of follow-up data, that tends to come over time. And there's a huge amount of what we do that still falls into level of evidence C. And it's remarkable how many things we do and that we swear by that are in fact not supported by a single piece of scientific research. But the fact we all do it and the fact it's deemed the right thing to do is, of course, relevant and powerful in its own right. And those things are given level of evidence C. And there's quite a lot of 1C in the guidelines. In other words, things considered to be mandatory, but not supported by evidence, which is interesting. So I'll make things easy for you. We'll start with diagnosis. Nothing has changed. The only comments in the what's new section about diagnostic tests or diagnostic process for heart failure don't even get a whole slide. Half of this slide refers to diagnosis, and all it is some minor shuffling of the priority in terms of right heart catheterization. So the diagnostic process And this is what the current NICE guidelines look like in terms of their kind of diagnostic slide. This is the same. And the ESC have a very similar slide, which I'll show you in a minute. But the diagnostic process for diagnosing heart failure has not changed. So do not waste any of your brain cells worrying about diagnosis. What you're currently doing, or what the people referring to you are currently doing, is correct. They are suspecting heart failure based on symptoms and signs. They're doing an NT-proBNP, and they're using that result to refer into heart failure services, including an echocardiogram. And then from there, the usual diagnostic tests are available, as they always have been. And this is the same slide. This is the current slide from the ESC guidelines. The only thing that's different in the ESC guidelines, and this is not a new change, this has been the case for some time. I hope you can see my pointer. The ESC have always focused, if you like, or had this additional class of heart failure patients. So we tend to talk about reduced and preserved. ESC has always recognized that there is a group that falls in between, what they call the mid-range ejection fraction group, or the HEF midriff, whatever you want to call it. And the reason for that is that when you look at scientific data referring to preserved ejection fraction heart failure, you have to be very careful to break down what group of patients they're actually looking at. And a lot of trials have looked at patients with an ejection fraction above 40% and called those patients preserved, because their ejection fraction is above the current cutoff for most of the treatment that we have evidence for. But of course, there's a world of difference between someone who has an ejection fraction of 41% and a person who has an ejection fraction within the normal range. And so to kind of reflect that difference, the ESC has always had this additional category of patients. Although until now, there's been very little really in that category in terms of what to do with them. And I think part of the reason they created this middle group was to encourage more research and to reflect, or if you like, to sort of document the fact that we don't really know what to do with those patients, or at least we don't know what to do based on some of the traditional evidence that we have. And interestingly, as I'll show you, there has actually been some change in terms of how we should approach these patients, and I think it's going to make our lives much easier. Just to quickly run through the diagnostic section, as I said before, it's remarkable how much that we do and that is considered to be the right thing to do is not supported by a single jot of evidence. There is no evidence for using echo in the diagnosis of heart failure, which is incredible. The only thing actually within diagnostic testing that carries any evidence base at all is BNP testing, and that absolutely should remain the forefront of what we do. But the usual tests are all still in there. MRI scanning is used, as you know, for patients either where echo hasn't given us an answer about what is the cause of their heart failure, or to further characterize in more detail what's going on within the myocardial tissue, which is relevant in lots of conditions and useful for assessing scar burden and evidence of fibrosis, which is very important in terms of making device decisions and recommending ICD implantation, etc. There's been a little bit of shuffling around coronary angiography, and I'll show you this again in a few minutes, but it's certainly by no means mandatory to investigate people for underlying coronary artery disease, particularly if they don't have angina. But if they have angina symptoms reasonably enough, it's worth looking at their coronaries to see whether there's anything we can do to help with those symptoms. But beyond that, looking with invasive coronary angiography is now considered only a 2B recommendation. And if you do want to look at coronary arteries, then CT coronary angiography has kind of risen up the pecking order and is now considered to be a better option for looking at coronary anatomy in the majority of patients, which I think is a very reasonable thing to say, and I think is in line with other guidelines and very much in line with clinical practice. Cardiopulmonary exercise testing remains something that only really needs to be done in patients who are being referred for advanced heart failure treatment, in other words, transplantation or mechanical support. But it does have a role. It does have a role elsewhere, particularly in patients where your investigations so far have not really given you an answer as to what's going on. Cardiopulmonary exercise testing can be very helpful for those patients. Again, right heart catheterization is mandatory for those being referred for heart transplantation, but has a role in other conditions. Most of these are, relatively specialist, if you like, within the umbrella of heart failure, such as pericardial constriction, pulmonary hypertension, etc. But nothing has changed in these indications. And finally, biopsy, which is not something we routinely do for heart failure patients, of course, but is still recommended for those patients presenting with sort of rapidly progressive heart failure with malignant arrhythmia, where you suspect an aggressive myocarditis. So I'll just pop that back up. The diagnostic pathway essentially unchanged, based around BNP and then echo to decide what group of which class of patient you're dealing with, and therefore what treatment they should be offered. So, medical treatment. And as Alison referred to, these are the guidelines we're currently working with in the UK, the NICE guidelines from 2018. And more as time goes on, they don't reflect certainly how we're treating people here in Brighton, and I suspect they don't reflect how you're treating people either. And they're also quite difficult to use, I think. There's very little clarity within these guidelines about what's important and what isn't. I hope if you can see my pointer at the bottom, for example, there's all these extra options at the bottom, and it's not really clear which one of them you should go for. If your patient remains symptomatic, should I be switching them to sac-val, or should I be giving them hydralazine and nitrate or digoxin? And of course, the evidence for these things is vastly different. And so I think these guidelines, the way they're written, is unhelpful. Devices sort of get stuck on this sort of naughty step in the corner where they're just mentioned, but with absolutely no guidance as to what you should really be doing with any of this stuff. So it's really refreshing to see the changes in the ESC guidelines, which I think not only have kind of caught up with the evidence, but also have actually made it a lot easier. And Alison's rudely already given the game away that the big headline news is that, of course, the SGLT2 inhibitor class of drugs, specifically DAPA and empagliflozin, are now recommended for treatment of our heart failure patients with reduced ejection fraction, and they're given a class 1A recommendation. I'll show you some slides about vericiguat in a minute. Possibly the hardest drug to pronounce I think I've ever had to work with. So I'm kind of hoping that the evidence will show that it's no use and we don't have to use it. But there is always something just before a guideline is published. There's always a drug that's just published a trial that looks quite impressive, and clearly this is the one that was fresh in their mind, so it gets a mention. There is only one study. The benefit of this drug is of questionable benefit, but there is no question that there's a suggestion that it could be useful for a select group of our patients. I think that's an unfinished story. There's going to be further research to try and understand who really benefits from this, and you may see this come more into kind of clinical use over the coming years. But for the time being, I wouldn't focus on it. I think the SGLT2 inhibitors are the only major change in terms of first-line medical therapy. As I said before, what's interesting and encouraging is that there has also been some change to what we do with these mid-range ejection fraction patients. In the interest of the time of this talk, I haven't brought all the slides about this topic because it's a huge thing to talk about, but there are all sorts of bits of data that show that ejection fraction of 40% probably is the wrong level, and that actually patients with ejection fractions below the normal range will benefit from the treatments that we give to people in the reduced ejection fraction category. In other words, reduced means reduced, as in any level below normal. And so to reflect that, the ESC have given permission, albeit only with a 2B recommendation, but they have given permission for the same drugs that we use for reduced ejection fraction heart failure to be used for mid-range ejection fraction heart failure. And I read this as, forget that this group exists. Treat everybody the same who has an ejection fraction below 50%. And I think if you do that, not only will you be treating people better, but actually it makes clinical practice a hell of a lot easier. I'll talk a little bit more about HFpEF later. But there's certainly no question that we now have quite a lot of treatment for these patients. And it's just all about mentality and how you approach them. Lots of people will say, this patient has preserved ejection fraction heart failure. There's no treatment that really works for them. We just need to treat their comorbidities. I would challenge those people to sort of say, well, when you say treat their comorbidities, what are you doing about that? What are you actually treating? And it's all well and good saying it, but what are we going to offer these patients to treat their comorbidities? And in fact, if you think about your typical preserved ejection fraction heart failure patient, and I don't mean someone with pulmonary hypertension, I don't mean somebody with cardiac amyloidosis, I mean people with diastolic dysfunction, the typical kind of constellation of heart failure symptoms in an elderly patient with AF, hypertension, diabetes, etc., etc. And I would argue that if you give that patient the proper treatment for those comorbidities, you will end up treating them with essentially all the same drugs that you give to a reduced ejection fraction heart failure patient. So this idea that we can't really treat these people, that we can't give them the same medication, that they're a totally different cohort, isn't really correct. We may be treating for a slightly different reason, but you will provide a lot of benefit for your average HFpEF patient if you give them a beta blocker for their atrial fibrillation and their coronary artery disease, if you give them an ACE inhibitor for their hypertension and their CKD, if you give them an SGLT2 inhibitor for their CKD, and if you give them an SGLT2 inhibitor and other treatment for their diabetes. And so really, these patients end up on much the same treatment. And the National Heart Failure Audit shows us that if you treat all-cause heart failure with what was the last audit I looked at, triple therapy, what will obviously now be 4-pillar treatment, then the outcomes improve in a stepwise fashion the more treatment you give to patients, irrespective of whether they have a reduced ejection fraction or not. So I think this is a really important area. I'm going to whiz through the rest of the sort of medical treatment because this is really the most important slide. These are the treatments that our patients should have. These are 1A recommendations. This is not a matter of opinion. These are things that make people live longer, live better, stay out of hospital and feel well with reduced ejection fraction heart failure. And there are 4 of them, and every single patient with reduced ejection fraction heart failure should be on these 4 drugs. The other thing you'll notice, those of you who are shrewd, is that angiotensin receptor blockers are no longer in this list. It is ACE or it's ARNI. ARB is very much now a second-line treatment for people who can't tolerate either of those drugs. There's very little clarity about which you should choose, and technically it's still ACE ahead of ARNI, if you like, but they're very much put side by side in the guidelines now, and I interpret that you have a choice and you can use either. Beta blocker, MRA, SGLT2. And of course, this is why. This is the data that we have that supports the use of these drugs. And every single one of these agents carries massive evidence weight of the benefit that they can provide. This is the data from DAPA-HF. So this is treating people with SGLT2 inhibitors, 26% relative risk reduction, about 4% in real money. So 4% in absolute risk reduction of either death or heart failure hospitalization, and nearly a third reduction in heart failure hospitalization in these patients. And you see this benefit within 28 days of starting treatment. So statistically significant benefit within a month of starting treatment. And cardiovascular death, if that's what you're interested, is also reduced independently. We know ACE inhibitors work. You can see from how grainy this slide is, you can see how old it is. Enalapril has been around for a long time. That was the drug first proven to be beneficial in these patients with about a 5% absolute risk reduction of mortality. But of course, we know that sacubitril valsartan, at the time known by the rather catchy moniker of LCZ696, shows about the same benefit again on top of enalapril. So I struggle to understand why anyone would choose to use an ACE inhibitor when you have a drug that's proven to be, roughly speaking, twice as good. And as we showed in this trial, you see a roughly 5% absolute risk reduction, 20% risk reduction. But unlike all the other drugs, this is trialed against ACE inhibitors, not against placebo. So there's no question that this is the single best medical treatment we have for heart failure with reduced ejection fraction at the sort of current time. Beta blockers, this is the same data but the other way up. So this is the bisoprolol trials. CIBIS-2, and this shows again about a 5 point something % absolute risk reduction in terms of mortality. So bisoprolol keeps people alive with reduced ejection fraction heart failure. And this is the data for eplerenone from the class 2 heart failure study Emphasis, showing again around a 6-7% reduction in either death or heart failure hospitalization compared to placebo. So every single one of these treatments, this kind of 1A list, they all have these big trial-based databases behind them to show that they are the right treatments to give our patients. The rest of medical therapy is all the same things we've used for years. Nothing has really changed. Diuretics are recommended, but of course, we don't have any evidence that they're beneficial. In fact, the only evidence that exists for loop diuretics is that the more you're taking, the worse your prognosis is. Although I doubt that that's caused by loop diuretics, it's just reflective of progressive heart failure symptoms. As I say, the ARBs have been reduced to a backup option if people can't tolerate ACE or ARNI. And interestingly, there's been a slight shuffling behind loop diuretics. So adding a thiazide has been promoted from a 2B to a 2A. And that's very much been our approach, more recently. And giving vasodilators to patients as an add-on is very much less popular now and has been reduced from a 2A recommendation to a 2B. And there's a theme here. The use of hydralazine and nitrate has generally dropped in the guidelines, as it should have done. It is not a treatment for people with reduced ejection fraction heart failure who can't take an ACE inhibitor, and it never should have been used as such. And it's been very much kind of corrected in the guidelines, as I'll show you. Ivabradine still in, underrated, underused. It's a great drug for people in sinus rhythm with reduced ejection fraction heart failure, particularly those who either can't tolerate a beta blocker or whose rate remains poorly controlled. Taking a beta blocker, it is an excellent add-on, and it helps to add a huge amount of benefit for these patients. It's also better tolerated in terms of side effects. So particularly a lot of younger patients don't like being on big doses of beta blocker. They feel tired, they get erectile dysfunction, they feel rubbish. And reducing their beta blocker dose and adding in ivabradine is a very acceptable option for improving their treatment. And there's good data to support doing that, provided you keep their resting heart rate below 70 or 75 beats per minute. And of course, this is the data that supports that from the SHIFT trial. I talked about vericiguat earlier on. So this is a soluble guanylate cyclase stimulator, and this has now crept into the guidelines on the basis of one trial, which is slightly surprising. And I'll show you that data in a second. As I said before, hydralazine and nitrate have very much been binned out of the general guidelines. They've been dropped down to a 2B for people who can't tolerate an ACE, ARB or ARNI. And in fact, they now have their right position in the guidelines, which is that they are for Afro-Caribbean patients with reduced ejection fraction heart failure with left ventricular dilatation. And that, of course, is the evidence from the AHEFT study in 2004. Their use otherwise is very much a piece of history and should be treated as such. So this is what vericiguat is doing. It's a soluble guanylate cyclase stimulator. And this is the same bit of science and principle to do with endothelial dysfunction and the role of nitric oxide within the vasculature that has led to lots of other attempts to sort of treat in this area. But it seems like this drug might work a little bit better in terms of directly correcting this cyclic GMP deficiency that we see in patients. The evidence is there, but it is borderline in terms of its significance. You will see how close to one a lot of these 95% confidence intervals are for various bits of the outcome. No mortality benefit, just about a heart failure hospitalization benefit. And so I think we really need to look in a bit more detail at where this fits in our armory. And I very much do not consider that this is a sort of routine treatment at this stage. And poor old digoxin, as usual, right at the bottom of the pile, in the corner. And it is an option for some of our patients, particularly if you've run out of any real treatment to give them. So I'll run through the other bits. It's very simple. There isn't really anything controversial in this guidance at all. and it covers all the other things we can offer our patients. We should treat severe aortic stenosis either with TAVI or with surgical aortic valve replacement, and there's a certain amount of freedom given to the choice between those two, but of course in the UK anyway, these are decisions not generally made by the primary heart failure team anyway. And mitral valve repair, percutaneous mitral valve replacement, has also come into the guidelines with a 2A recommendation for patients if you feel strongly that it can have a positive impact on their heart failure hospitalization. Screening for and treating iron deficiency is in the guidelines, as you'd expect, with the criteria copied and pasted from the FAIR-HF study. In those patients who have proven amyloidosis, then there is a class 1 recommendation for the use of tafamidis for patients with transthyretin amyloidosis. So the transthyretin stabilizer tafamidis is now recommended with a class 1 indication for the patient, for the right cohorts of patients with transthyretin cardiac amyloid. I'm going to talk about this at the end, so I'm not going to dwell on it now. It looks like on paper there's been a reduction in the recommendation for ICD and CRT implant in some patients, and I'm going to tell you at the end of my talk why I strongly believe that that's the wrong advice. But it's all still recommended. ICDs for non-ischemic patients are still recommended. They've just reduced the power of that recommendation from 1 to 2A. I'll show you why, and I'll show you why I disagree with that later. And the same for CRT patients with narrower QRS complexes. So left bundle branch block, but a QRS below 150, again, has dropped to a 2A recommendation. Upgrading patients to CRT, however, has come up in the recommendations to 2A. So anyone with reduced ejection fraction who's pacing their right ventricle should have an upgrade to CRT, which is about 10 years behind what we do clinically. There's lots of areas where I think the guidance has been made much simpler. And one of them is that for patients with atrial fibrillation, they should all be on a DOAC rather than warfarin, unless, of course, they've got either significant mitral stenosis or a mechanical valve. So that's easy, simple, and again, I think that reflects what everyone's doing anyway. And there's also been an uplift in the recommendation for ablation for these patients. So for patients with atrial fibrillation where the AF is driving their heart failure, then they should be offered ablation with a 2A recommendation, which again supports what we're doing. I like this section, which is crept in, which is about primary prevention. It kind of feeds into what I was saying about heart failure with preserved ejection fraction as well. I feel like the two areas overlap. And as our outcomes generally level off in terms of secondary prevention, we do need to look beyond treating the patients who are coming to us, and we need to go looking for patients who are at risk of developing heart failure. And those patients should have their blood pressure, their cholesterol, their diabetes managed aggressively, and generally with the same sorts of drugs as we use for treating heart failure patients. And there's very good evidence that supports that. So, commendably, the ESC have managed to get all of what I've just told you onto one slide. And I think you're going to be sent these slides today, so you can print this out and put it on your wall to look at, maybe alongside a picture of your family or something. It's sort of equally important in your life. But they've managed incredibly well, I think, to get everything onto one slide, and they've laid it out really nicely. We should be giving 4-pillar treatment to all our reduced ejection fraction heart failure patients. And then beyond that, there's this whole list of extra things that we can be doing for them, as appropriate. So you can work through and sort of tick off which of these apply to your patients and make sure that those treatments are considered. And then if none of that's working, then they might need a transplant or mechanical support. And all of this should be managed with access to an MDT and with access for the patients to cardiac rehab. So I think it's a really nice slide. It really summarizes things very nicely. So I'm going to spend the last couple of minutes of my talk just talking a little bit beyond the guidelines. I don't recommend you pay too much attention to what I'm about to say unless you're particularly interested. I think what I've already told you is far more important in terms of the changes. But there are a couple of areas, as I said earlier, that I don't necessarily agree with, although I can understand why they've changed in the guidelines. And CRT is one of those. So CARE-HF was the original landmark study that showed a benefit for CRT in patients over and above medical therapy. This was a UK study run by John Cleland, of course. And then through the sort of early 2010s, whatever they're called, teenies, I think they're called, before the last iteration of the guidelines was published by the ESC in 2016, there were a few trials, and this is RAFT, which was one of those studies, that showed a benefit for these patients if you treat them earlier. So the indication for CRT was expanded from class 3 heart failure to class 2 heart failure. And that was principally driven by data like this. If you look in the bottom left here, for class 2 symptoms, you can reduce mortality by putting CRT in. And this is not an ICD thing, because this was ICD versus CRTD. So just by adding CRT rather than ICDs alone, you improve people's mortality in addition to treating their heart failure symptoms. You don't achieve that in the class 3 patients because you've left it too late. And what RAFT also showed us, this is the forest plot. If you look at CRT beta being on the left-hand side here, you can see that there are distinct groups of patients who seem to benefit much more than others. And those are patients with a broad QRS above 150 milliseconds, which is this group here, those with left bundle branch block, which is this group here, and women. Now, it's very difficult to say you should only give a treatment to women instead of men. That's going to be pretty hard to carry through sort of ethically and politically. But the guidelines in terms of CRT implant were pretty much lifted from this study in 2016. Left bundle or a QRS above 150 milliseconds was given a class 1 indication. So what's changed to mean that they would have reduced that in the power of that recommendation from a class 1 to a 2A for patients with the less broad QRS complexes? Well, it's all really down to this study, which was a study called Echo CRT, which was looking at whether we could offer CRT to people with a narrow QRS, if they had dysynchrony, and the answer is that that does not work, and those patients receive no benefit. And so what was shown in that study, unfortunately, was that if you put CRT in the wrong patients, then you actually cause harm. And it led to quite a lot of pullback in various guidelines around the world in terms of recommending CRT quite so readily. And I think this is what we're now seeing the extension of in the current iteration of the Esc Guidelines. So it's still a recommendation, but there's an element of caution there. However, why 150? If you look at the benefit from CRT in all patients, and this is an individualized patient data meta-analysis published by John Cleland, if you look at benefit in terms of mortality or heart failure, which is this bottom graph, this is the QRS width along the bottom here. This black line is the average QRS where people receive benefit in the trial, or it's the average QRS rather, and where it crosses this line is where you get benefit. And you can see that that is nowhere near 150. It's down in the low 130s, so around 132 milliseconds. And statistically, 95% estimate, there is no question about benefit once this line crosses, which is again around 144 milliseconds. So this idea that we should not be offering CRT to people with QRSs below 150 is not supported by data. And in fact, if you're going to put a QRS width cutoff on CRT, it should be closer to 130, not 150. And if you this is the same data, but with men and women separated out, the red line being women. If you're female, you can see that the benefit, all these lines move even more. This is the mortality heart failure at the top. They move even further across, and you can see it crosses way below 130 for women. In addition, there is strong data ignoring QRS width, but looking at morphology from all the old landmark CRT studies that shows that left bundle is actually probably the better predictor of response to CRT than anything else. And if you divide these landmark studies up by their morphology, you can see that there is massive benefit for the patients with left bundle and much more questionable benefit for the patients with right bundle or non-specifically broad QRSs. So I would argue that if you have left bundle branch block, whatever the QRS width, and you have impaired ejection fraction heart failure, you should have CRT. And it is as simple as that. And that is supported by the data. In terms of ICDs, again, there's been a change in the guidance that for patients with non-ischemic cardiomyopathy, so of a non-ischemic etiology with reduced ejection fraction, can still have an ICD, but the strength of that recommendation has been reduced. And that's quite simply drawn from the Danish study, which was published just after the last set of guidelines were published in 2016. Now, this showed, if you look at this on paper, you can see why the guidelines would have changed, in that this is ICD versus medical therapy for people with non-ischemic cardiomyopathy. And there appears to be no benefit at all in terms of general overall mortality and cardiovascular death, although there is a reduction in sudden cardiac death. So that's the end of the story, right? Well, as usual, the devil is in the details. And if you look at the patients in Danish, this trial is published as being medical therapy versus ICD. What it in fact is CRTP versus CRTD. And what you see here at the very bottom, just at the bottom of this, is that the number of patients within the trial receiving CRT is the majority. So 60% of patients in Danish received CRT in one format or another, CRTP versus CRTD. I've just told you that CRT works without question above a QRS width of 144 milliseconds, and look at the average QRS duration in this trial, 146, 145. So these were CRT candidates. They should have probably all had CRT. Most of them did. And unsurprisingly, if you treat non-ischemic cardiomyopathy patients with broad left bundle type ECGs with CRT, they all get better. And therefore, a lot of them will not need an ICD. And that is what Danish showed. What it did not show is that patients with non-ischemic cardiomyopathy shouldn't have an ICD. And if they don't have a CRT option, and you don't think you can improve their ejection fraction, or if they fail to respond to medical therapy, then these patients absolutely should have an ICD. And if you really want data to support that, then I'm afraid there is nothing better that has been published since 2004. And SCUD-HEFT remains the only trial we have that looks directly at that cohort of patients. And that shows that if you have an EF below 35% and symptomatic heart failure, then treating them with placebo in terms of device leads to a substantial increase in their mortality. So be very careful when you tell a non-ischemic cardiomyopathy patient with a low ejection fraction that they don't need an ICD. I'll finish very briefly with this medical therapy sort of section. One of the reasons why I don't think we should be using ACE inhibitors anymore, particularly in patients who present acutely, i.e. patients who are in hospital when they're diagnosed with heart failure, is that there is strong data from this study called Pioneer that if you treat patients early with sacubital valsartan instead of ACE inhibitors, you see a significant or relative significant improvement in their BNP levels during that index admission, and they go home better treated. It also potentially allows you to get them onto less, or have them on less loop diuretic, which is probably a good thing. I thought I'd better chuck in one bit of kind of horizon scanning science. And those of you who've been paying attention to the data will have seen the trial Galactic, which is a study of a drug called omecamtiv mecarbil. A hell of a lot easier to pronounce than vericiguat, so I may be hoping that this one is the one that makes it. And this is an oral drug, not unlike the benefits of giving people levosimendan, so you get an increase in cardiac contractility without an increase in kind of metabolic demand. And the data from Galactic seems to suggest that it's beneficial for patients in terms of reducing their hospitalization or mortality. But again, it's very close to the line, and I think the place for this is yet to be proven. Finally, I'm going to finish by backing up what I said earlier about heart failure with preserved ejection fraction. I showed you the benefit from treating patients with reduced ejection fraction heart failure with dapagliflozin, with SGLT2 inhibitors. But this is data from DAPA-CKD. So these are not heart failure patients. They're not even cardiac patients. These are renal patients with renal failure being treated with an SGLT2 inhibitor in addition to an ACE inhibitor for chronic kidney disease, okay? Nothing to do with cardiac. Look at the improvement in their cardiovascular outcomes cardiovascular death, heart failure hospitalization reduced by nearly 30% when you treat renal patients with a drug for their renal failure. So this is exactly the benefit you can offer patients. And when you talk about let's treat the comorbidities of this patient, this is what we should be doing. We should be looking for, finding and treating things like chronic kidney disease. And we can offer them a treatment that we know is nothing to do with their kidneys. We know we're treating the heart, but we can do it now. The data is there. Dapagliflozin is licensed for treating patients with chronic kidney disease. You are allowed to give this drug to those patients, and we should be doing it. And this is the kind of benefit we can achieve if we do that. And of course, it's going to get even easier, because at the latest ESC Congress, we saw data for treatment of heart failure with preserved ejection fraction with SGLT2 inhibitors as a direct indication. And this is the Emperor preserved data, which shows for the first time a drug making a significant dent on mortality and heart failure hospitalization in the context of preserved ejection fraction heart failure. So it feels like we should be putting SGLT2 inhibitors in the water. It feels like there's virtually no patients out there who shouldn't be on them for one reason or another, but there's very good science and very good data to back that up. In summary, the diagnostic pathway hasn't changed. All our patients with reduced ejection fraction heart failure, and reduced means anything below normal, should be having 4-pillar medical therapy. I think the other aspects of the guidelines have been made much clearer and simpler in terms of how to manage comorbidities like valve disease, atrial fibrillation, diabetes, etc. And the ICD and CRT indications are clear, although I think they're somewhat they somewhat undersell the role of devices in certain cohorts of patients. And within the guidelines, this is my last slide, I'll leave this on the screen. There's this really nice slide as well, which just covers the class 1 recommendations in the current ESC guidelines. So I think particularly for those people maybe outside of specialist heart failure teams, outside of cardiology teams, you know, for sort of people coming across heart failure patients in their day-to-day life, these are the things, if you do nothing else, these are the things that make the biggest impact for our patients, and they have the strongest support and the strongest level of recommendation. And so for reduced ejection fraction heart failure patients, it's the 4-pillar drugs, it's CRT and it's ICDs. Thank you very much.
Thank you so much, Steve. That was an amazing overview. I can't believe how much information you managed to get in that period of time. I'm sure everyone's
breath now.
Yeah, I'm sure everyone's still digesting. There are a few questions coming up in the chat box, but we might have to pick those up outside just from time really for this morning's meeting. But I'm sure I'm joining everyone in saying thank you so much for joining us and for that overview. Leaving everyone there with a lot to digest, so we're just going to make their brains blow a little bit more by moving on our programme to Jen Bailey. I'm sure there's a lot of you on the call today who know Jen. She's been integral in the management of our patients for many years. She works for the Kent, Surrey and Sussex Academic Health and Science Network, and she also works for the Sussex Health and Care Partnership. And for those of you who've heard Jen speak before, you know she has a passion for data, and she's going to give us an update on what's happening around data and what we should be looking for, perhaps in terms of developing how we can input into data and use data. Thank you, Jen.
Thanks so much. Good morning, everyone. I'm going to just share my screen. So we're just going to go through a couple of things this morning, and please feel free to add questions or comments or feedback or whatever you feel in the chat about as we go through this dashboard. So I'm Jen Bailey, and thanks for the introduction, Sarah, Alison. My background is actually a community heart failure nurse for many years in Brighton, and so I've always, from the outset of these heart failure dashboards, been very involved, even in my clinical role in the community heart failure service. So the programme, as we knew it as EQ, and I'm quite keen to go back to EQ. It rings bells, it's familiar. Enhancing quality in heart failure. So we developed dashboards years ago in 2010, and then in 2015 we merged the data in the Acute Trust with the National Heart Failure Audit, and so it was for the purpose of data collection, so that you weren't double data collecting. Then in 2020, the EQ heart failure dashboards were paused because of the COVID-19 pandemic. We didn't want to sort of add anything else whilst we were all going through the start of that pandemic. So we put it on pause and then made it optional if people wanted to send us data. But we actually took that opportunity to relaunch the or redesign and put the dashboards on a web-based platform so they were faster. I think probably any of you that have seen the dashboards before recognise that they were on a clunky Excel spreadsheet that nearly crashed everyone's emails whenever we sent them out every month. So there's a lot of data going on there in terms of the hospitals that are involved, and so we've now put it on a web-based platform. It's going to be much faster, and we're going to send it out next month. The monthly data will display in trends. It will be aligned to the latest version of the core mandatory fields of the National Heart Failure Audit, which has got a lot more detail in it this time. We'll go through it soon. And then reporting at the regional level, at ICS level, trust level, and then hospital site level. So in the dashboards, there are 7 acute care bundle measures. So that's sort of whether you pass or fail the measure of whether the patient receives that care for those different process measures when they arrive into hospital and on hospital discharge. It also aligns with the outcomes data and then looks at the best practice tariff achievement for each hospital and trust every quarter. So we've got 16 hospitals that implement the acute care bundles, and they submit monthly data to Kent, Surrey and Sussex. And their first report that you'll be getting will be on the 26th of November next month. So building on the firm foundations, and this makes me feel really old that I've been involved with this programme for this many years, but we've been working on this for 11 years. But it's ready to scale, and now it's on a web-based platform. It's available to any hospital in the country to sign up and get started and receive these monthly reports. So the reports, I hope, will give those hospital services a robust tool to demonstrate what they offer and deliver in terms of improving quality, reducing variation, and placing patients at the centre of change. So the setup process is, and all KSS hospitals are sort of involved in this and have been for many years, and there's certain bits that we're trying to tidy up for Kent, Surrey and Sussex hospitals now. Everyone will get an implementation pack. Everyone, we're going through the process of getting data sharing agreements, getting all of the data up to date so that we've got a sort of really robust amount of data to be displaying for you in your monthly reports. You'll get a unique ICS login to view the dashboard, which will be password protected, but there'll be one for every ICS, and anyone in that ICS will be able to access through that unique login and password. So the setup is how you already input your data into the NICOR database, and then there is an extraction of that data of all the core mandatory fields data coming to us so that we can deliver you monthly reports. So this is just a map of Kent, Surrey and Sussex and all the hospitals that are set up and signed up to receive these monthly reports. So that's 16 acute hospitals. So the population, this is the National Heart Failure Audit. We're following the exact data detail of this audit. So it recently updated to the latest data set, and these are the patients and the cohort that they're looking at in terms of have they been coded as one of these codes as their primary diagnosis of heart failure. So the data, it's reporting at regional, trust and hospital site level. It's non-patient identifiable data. It's patient level aggregated data. There's benchmarking across hospitals and trusts for the region. There's reporting on process measures and information only fields as per the National Heart Failure Audit data, which we'll have a look at. There's reporting on outcomes, admissions, length of stay and mortality data, which is through the HES data, the hospital episode statistic data, which is separate to the National Heart Failure Audit. There's reporting on the National Best Practice Tariff Achievement, which is bespoke to your hospital. So that's a quarterly payment or a quarterly amount that you need to demonstrate that you're achieving, which we'll have a look at as well on the measures. There's data reports that are displayed in the trends, months and years, and the acute care bundle I've listed there. There are 7 acute care bundles. So that's around whether you've passed or failed the measure, whether that patient has received, if they're eligible for that medication, have they received that medication on discharge? And then the acute outcome measures, which is through the HES data, is looking at their discharge spells. So were they discharged, were patients with a primary diagnosis of heart failure discharged from hospital, their numbers, the length of stay, the in-hospital crude mortality, and the readmissions at 90 days. So what's the aim? It's to provide quality through the process measures to try and ensure that every patient receives that level of care. The outcomes, looking at the admissions, the length of stay, mortality, and then how we link that with our finance. How do we link that with our best practice tariff and our outcome cost modelling? So the benefits of the data and the dashboard. Data's evidence, isn't it? But evidence is only as good as we input into the data, but we're all inputting into this National Heart Failure Audit. And by pulling it out of the audit in this way that becomes a monthly sort of a monthly report for you to be able to build on your business plans, to be able to evidence base your service and what you do and what you deliver, it gives you a view of what you're achieving for your hospital in terms of bringing that tariff back into the hospital because you've achieved it. Where does that money go? Does it go back into your heart failure services? Reporting to this, it will support your workforce planning and service delivery. It will look at shaping your future budgets. It will help you to deliver real-time data evidence of your heart failure care and outcomes in your hospitals. So Sarah's here today, and Sarah was very kind to give us a bit of feedback from their experience of the dashboards in the past, which were, it's easy to use and it provides timely data on quality heart failure metrics. And they've used it in their business plan to demonstrate the previous inequity of care across 2 hospital sites. So that business case was submitted and it proved successful, and it resulted in them increasing their workforce and being able to appoint a heart failure consultant and a nurse specialist based on using that data. So how will the new dashboards be different? They're going to be a new look, and I'm going to give you a bit of a live tour of them now. So in the live tour, please write any comments in the chat, or at the end we can have a chat through, but I'd be really keen to hear what you feel about the dashboards and how you might use them. So first of all, I would like to say a huge thanks to Dr. Richard Blakey, who's our AHSN clinical lead. He's on the call today. He's been instrumental in working with me to understand and pull out the National Heart Failure Audit outcomes and work through those algorithms. But I think the biggest thanks and the biggest just drum roll please is for Justin Rowcliffe, who's the senior analyst who, you know, has created this amazing dashboard that I hope you will find really helpful in your day-to-day, but also in building and providing evidence for your services. So this is the landing page. This becomes a navigation page. These are all the care bundle measures, and then these are the outcome measures, and then these are the fields for information only. So you'll be able to navigate through clicking into any of these, or you will also be able to navigate through the top tabs. So for the purpose of today, I'm not going to be looking at particularly any hospital. I'm not going to be filtering into any months, but just to give you an overview of that, we're looking at 2020 data to 2021. So that's a year's view. We can also look at every month, so you can filter it by month. You can filter it by ICS, so we've got Frimley in there, Kent and Medway, Surrey Heartlands and Sussex. And you can filter it by trust, so all the different trusts within those ICSs. And you can filter it by hospitals, so these are the hospital sites. So you can look at it on a financial year view, or you could look at it at a hospital level view for a month. So you can really get into some of the detail here. Here's an overview of all of the care bundle measures. So these are the ones whether you pass or fail through the algorithm. So has the patient received specialist input? If you hover over these, it tells you what we're asking, what the measure's asking. Atrial fibrillation and anticoagulation is a new measure, and that is I'll get into some of that when we look at the detail of the long-term conditions, but that's going to be able to pull out whether that patient was in atrial fibrillation when they came into hospital, and then whether they were anticoagulated, whether AF showed on their ECG, and there's a few lot of steps through the algorithm to take you through. This is whether they were on ACE, ARB or ARNI on discharge, and it's looking at what the sort of regional performance is over the year. It's looking at beta blocker on discharge, an echo, that's during admission or in the last 12 months, whether they've had a heart failure management plan, and whether they've referred to a heart failure specialist nurse follow-up, and that doesn't matter whether it's a community heart failure nurse follow-up or a hospital heart failure nurse follow-up for the purposes of the pass-fail. But we have split that out so that you can really get into some of that detail as well. This is the best practice tariff. So the tariff is based on a quarterly basis. So this is reporting on 2021 Q1, and it's showing that you are going to achieve as a region the tariff and how much money that equates to on a quarterly basis for the whole region. That then is split into the different quarters so you can filter, and further on I'll show you how you can look at that for your hospital in a bit more drilling down. So this is a map of all the hospitals that are sending in data. The colour of the marks indicate how the hospital compares to the regional average for crude mortality. So the dark red is much worse and the dark green is much better. But the more discharges are, the larger the marks are. So I think that just sort of indicates really how they've got more discharges. They're in a bigger circle, but they're a bigger hospital. If you hover over, and again, sorry, I don't want to be picking out any particular hospital, but if you hover over these hospitals, it tells you your length of stay, your mortality rate, and the discharges over that year. Remember, I'm looking at a year, not a month. So this is saying, again, is just where we are with the data. So we've got I don't want to hone in on anyone's data particularly. This is about giving a regional view and a flavour of the dashboard. This is about the medications on discharge. So the ACE, ARB or ARNI on discharge and the beta blocker on discharge are part of the care bundle. And then the MRA at discharge and the triple therapy are information only fields, but we felt it was useful to include these. This then looks at, you can hover over any of these indicators, which brings you into the month, and it talks about what your regional performance is or if you filtered this, it would talk about what your hospital's performance was on prescribing that drug on discharge. This talks about the patients that are eligible for those and the ones that passed. So that gives you a bit of a detail of the passes and fails and the patients that were eligible versus the patients that passed. This is your overall discharge performance on ACE and ARB and ARNI and beta blocker. And then your filters. So the next one is looking at the breakdown of these medications. So you've got your ACE, ARB. So basically, if you didn't tick it in the National Heart Failure Audit, it wouldn't come up on here. But anything that's been ticked is presenting here. And we haven't got the SGLT2s because we're going along with the National Heart Failure Audit and the exact data detail. So as soon as they add SGLT2s, so will we. It will appear here. Your echo is around have they had a echo within this admission or the last 12 months? Now, don't be too alarmed by this, because this is showing a drop since October 2020, but that's due to the National Heart Failure Audit data set. When it updated, it now actually asks you to put in a date that patient had the echo. So when we're looking at the algorithm for passing or failing, we're not only looking at whether you've ticked whether they've had an admission, an echo during admission or in the last 12 months. We're also looking to see what the date was, and then that takes you to passing or failing. So lots of hospitals have still got the old data set. So when they update the NICOR data set, this will improve. So don't worry too much. This is also looking at the main, what the echo results were. So a breakdown of all the different options that you've got on your National Heart Failure Audit data. And then you can click into it of significant hypertrophy, valve disease, and it sort of breaks down how many patients you've got. To get out of that, you can reset your filters. Looking at specialist input, this is around did they see a specialist in hospital? If you hover over, it gives you the breakdown per month of the nurse or doctor or other that they saw during their admission. This is a pass or fail measure. It's at 83.5 for the year, again for the year for the region. And then this is main place of care. So where was their main place of care during their admission for heart failure, and that's captured here. And it would also then, if you hover, it would tell you how many patients in each month were in each of those places. A management plan. So part of the care bundle is, have they had a management plan? Now, the National Heart Failure Audit in the latest data set has really been quite split out, and it's now looking at 3 different measures. So it's looking at, did they have a pre-discharge management plan in place? Has it been discussed with the patient? Has it been communicated to primary care? So we're really trying to capture there for you exactly how that's going, and breaking it down so that that can be sort of reviewed back at your hospital sites. Have they had input from a hospital or a specialist heart failure nurse is part of the care bundle, and is that follow-up appointment been referred out to either community or hospital heart failure nurses for a review? So we've just split these 2 out. So this is the hospital ones, and then this is the community ones in a different colour. And again, it only started in October, so hence why the community data is a bit less. This is looking at the appropriate care score and the composite quality score. This is around a measure of the did they receive that? So that's sort of plotting that out. And again, you can split that down into hospitals. This is looking at your outcome data. So this is looking at HES. This is your discharge, length of stay, in-hospital mortality, and 90-day readmissions. That the readmissions is HES only, because in the National Heart Failure Audit, you can switch over to the National Heart Failure Audit, but in the National Heart Failure Audit, they've merged admissions and readmissions data, so we can't separate. Wrong and starts whirring around. Okay, so this is looking at have you achieved the tariff, and again I'm looking at all the region or the ICSs. So it's whether you've achieved specialist input and whether 70% of your National Heart Failure Audit fields have been completed. That's what it's measuring you on. And then this is the potential money every quarter that your trust could generate for achieving the tariff. So it's a significant amount of money, really, isn't it? So long-term conditions, this again, it's all information only fields, but the National Heart Failure Audit puts so much more in this data set. It's really helpful. So this is looking at, and again, you can click into these. So this is looking at all these conditions, and you probably can't see it, it's really small, but AF, amyloid, coronary heart disease, COPD, CVA, malignancy, diabetes, hypertension, and then you can click into any of these and it shows you exactly, you know, how many hypertension that is, patients with heart failure that have got hypertension. This is looking at cardiomyopathy, the number of patients that there were, which was 192 no's and 16 dilated cardiomyopathies. This is looking about what your ECGs, as I mentioned earlier, this is looking at atrial fibrillation, whether they were, or what the other findings of their ECG were, whether the admission was a new diagnosis on admission or whether they were known to previously have heart failure, the device therapy, the QRS duration. And then this is looking at, and again, I sort of think this comes back to, oh, we have got SGLT. Oh, God, I didn't even know we had SGLT2. Sorry. So this is looking at where they went, where the referrals were. Did they have cardiac rehab? Were they referred to palliative care? Were they transferred to another hospital? Were they referred for a transplant? Were they on ivabradine at discharge or SGLT2s? I'm really pleased that's there. And then we've got resources. So you'll be able to click into any of these and this will bring you to the National Heart Failure Audit, or bring you to the NICE guidance, or it'll bring you to, you know, just a bit about your best practice tariff or our algorithms or any other information. So I really hope that's been useful, and I'm very happy if we've got time to have any questions.
Jen, can I just ask you to just update about what's happening from a community perspective? There's a few questions in the chat about the community, and I know we're going to discuss it within the breakout session, so it'd be useful for you to give a little summary.
Yeah, cool. So community, I mean, as we all know, the community dashboards we ran for many years as well, and then I think that was in 2015 as well. We reduced clinical staff to complete and collect this data, and that's a challenge. And when the pandemic started, you know, the community I think was the most important one to be paused in terms of the data collection is hard. So we've left it on pause. We made it optional as well to send us in the data, but we've kind of open to suggestions. But our latest sort of idea is how can we, bearing in mind that the DES CVD, the Direct Enhanced Service for CVD for GPs, that has recently been released, its first focus will be on hypertension, and then next year from April 2022 it will be looking at heart failure, early detection of lipids, FH, atrial fibrillation, and continuing with hypertension. So we are currently building a CVD data dashboard that actually will start to bring in quaff data from 1920 around heart failure, AF, hypertension and stroke, and it will look at your observed versus expected prevalence of the patients that you need to find to reach a target. I say you as in everyone. And that will become a baseline, and then I'm sort of very open to how can we feed data in from the community that doesn't burden the community teams to be collecting data on. Actually, if we could do it from a primary care perspective, how can the community teams then join and complement that bit of work? I'll stop there.
Thank you very much, Jen. I think that sort of leads in quite nicely. I'm going to introduce the breakout sessions, and then we'll have a short break. So, Sarah, if I could have the slides back on, that would be great. I think everyone would agree we've had a really meaty morning so far, with lots of really important information being shared. We want to use the next part of the session just to hear a little bit more from you. It's been great seeing the chat come in, and we're already picking up themes which we'll be taking forward. But we want to use this next part to hear a little bit more from you. Can I have the next slide, please? So the purpose of the breakout session is, you've already heard from Alison how this has been an important part of collaborative events when we've all got together face to face. It's very much an opportunity to share the work that we're all doing, share the good work we're doing, share the challenges. It also provides an opportunity to reflect. I think sometimes we don't realise how much we are doing without stepping back and talking about it. Importantly, it's an opportunity to network with colleagues. It's really hard, isn't it? You're all sitting in individual places, but we do want to get some conversation going, because that's how we learn and that's how we can be more powerful, learning from others. And then what we will be doing is using what we've picked up in the chat, but also what you talk about within the breakout groups to inform what we're going to do as a collaborative moving forward. So what are the collective pieces of work that would be really, really useful? Can I have the next slide, please? So we've got a breakout session following our own breaks in a moment, and there's going to be 3 themes, and there'll be a facilitator in each room to help sort of guide some conversations. But we want to focus on hearing something around patient experience and patient involvement. We want to hear something about the impact of digital technology during the COVID-19 pandemic and beyond. And also we want to hear a little bit more about using data to improve care for heart failure patients, and we will pick up on the community side of it as part of that conversation. So I think what we should do is have a 15-minute break.
We have another speaker, and it's my pleasure to introduce Dr. Vicky Parish. Many of you may know Vicky. She's a consultant cardiologist in Brighton. She's taken on a role within the cardiac clinical networks. These are newly established networks, and some of you may be aware of them, or some of you may not know very much about them yet, but she's kindly agreed to come and talk to us today about her new role as clinical lead for heart failure and non-invasive cardiology for the South East Cardiac Network team. So without further ado, I'm going to hand over to Vicky.
Thanks very much, Alison. I'm just going to share my screen. see the screen? So you can just say yes, that would be great.
Yes, we're back. We've got your screen. Thank you, Vicky.
Lovely, thank you. So thank you very much for the invitation to come and speak. As Alison's already mentioned, I'm a cardiologist. I work in Brighton. I'm not a heart failure specialist, but I have recently taken on this role for the network cardiac team, looking at the whole of the Southeast, looking specifically at non-invasive cardiology, so diagnostic pathways, imaging, and heart failure obviously comes within that remit as well. So I'm just going to really give you an overview today. My slides work? There we go. So an overview today of the National Cardiac Network and how the Southeast team fits into that, and what our plans are really for the immediate sort of next 6 months and going further on from there. So the National Cardiac Network is something that's been commissioned by NHS England and really is an opportunity to create a collaboration between primary, secondary and tertiary care centres so that we can enable patients to get the best care possible. This will help us to work out whether there are areas of inequality and also make sure that we are recognising good care and sharing that information across regional geographies so that cardiac patients can have access to optimal cardiac care. And this encompasses the whole range of cardiology, from community, preventative measures in the community, as well as community cardiology, right through to tertiary and quaternary cardiology care, as will be provided in centres throughout the UK. So the Southeast Cardiac Network looks like this. Obviously, there's a huge gap in the middle here, which is London, and many of the regions around the Southeast obviously have strong relationships with London as well. But within the Southeast Cardiac Network, we have 3 tertiary centres, that in Oxford, Southampton and in Brighton. You can see that it spans a huge geography with a massive population. And really the remit of the team is to look at how we're delivering cardiac services across that huge geography, identify the areas that need developing, and work with our ICS colleagues to try and make sure that patients within the region are having access to optimal cardiac care, especially looking at the tertiary centres for that very sort of high-level specialist care, but again working closely with our GP colleagues through our ICS collaborators to make sure that it goes sort of an end-to-end process from patients into the community through diagnostic processes to tertiary care if that's required. This is our current structure. Lots of very important people and very important sort of links to the hierarchy of NHS England. The Southeast region sits in the middle here, and our clinical lead is Chris Tibbs, and our cardiac lead is Yava Bashir, who's one of the consultants based in Oxford. And really this team structure was initiated back during the first phase of the COVID pandemic. We were asked to contribute to a weekly and monthly meeting on a regional basis, sometimes just for Sussex, sometimes more on a wide Southeast network regional basis. And that was a really good opportunity for us to share how we were managing through the crisis of those huge waves of COVID admissions, and how we were changing the way we delivered cardiac care for those patients. As a consequence of that, we were asked to structure a formal Southeast Cardiac Network, and this was initiated in April of this year. And we have a number of purposes of what we want to achieve as a Southeast Cardiac Network. And really the main sort of mantra of it is that we want to deliver safe, personalised and sustainable care with right treatments to the right people in the right places. And obviously that's what most of us who work in clinical medicine want to do for our patients all the time. But we have all of the difficulties of working not only in a post-pandemic or peri-pandemic period, but also the constraints of funding, working within the NHS, working with the difficult IT infrastructure that we all have to manage on a day-to-day basis. And so the real purpose of our network is to oversee how we can deliver this level of care for our cardiac patients. And obviously heart failure is a major work stream within that, because a huge population of our cardiac workload have a diagnosis of heart failure or heart failure associated with valve disease. So just to explain who we all are, so this is the sort of year one plan for the South East Cardiac Network. As I've already mentioned, the clinical lead is Yava Bashir, and then we have a split of subspecialty interest consultants and GPs who are supporting the service. This is quite different to the structure for cardiac networks that's been proposed previously, and some of you may have seen various different iterations of a proposal for cardiac network over the years. And the real difference here is that we've not split the representation at consultant level by geography. We decided to split it by specialist interest, as we felt that that would give a better oversight across the region, rather than relying on one specialist in Oxford, one specialist in Southampton, and one specialist in Kent. We wanted to make sure that all of the subspecialty interests in cardiology were properly represented, so that each of those areas had a true voice. And this goes right through from prevention in the community and on an epidemiological basis, right through to the sort of tertiary services in the surgical centres. And you'll see here a variety of individuals who do span the geography but have very different clinical interests. And if you look at the cardiac improvement programme, which is what the South East Network team will be looking at very closely, this is what the National Heart Failure Cardiac Pathway Improvement looks like. So it's hugely detailed. It is very much what is the optimal way of delivering heart failure services. And it is what a lot of centres are striving to do and often achieving. But obviously it has huge complexity and a number of different components, starting right at the initial assessment through to specialist treatment with device therapy, and then going on to the return of those patients into the community, how they are managed, whether they need palliative care input, whether they have access to rehabilitation. And so taking on the heart failure work stream is a huge challenge, and has a number of different arms and crossover areas that obviously I will be trying to focus on in my work as the clinical lead for this work stream. This is the decisions and sort of remits for the national plan have also taken into consideration the National Girth Review for Cardiology and also the long-term plan. And really the objectives are that we need to make sure that we're reviewing the current practice and establishing appropriate recommendations for patients with heart failure. And there is obviously a crossover with patients who have heart failure due to heart valve disease. We need to make sure that primary care are able to use clinical evidence within their MDT infrastructure. There needs to be good access to heart failure specialist nurses, and we need to determine whether there are regional variations for access to this specialist service. We need to make sure that patients have access to personalised care plans, if that's at all possible, with the aim to reduce admissions and to reduce unnecessary drug spends. One of the biggest challenges we have post-pandemic is access to echocardiography. I'm sure that a number of you have found that particularly challenging, and certainly we have had big problems with that in the Brighton region. And we need to look at ways in which we can improve those services, encourage more individuals to be trained to deliver those services, or make efficiencies within those services that allow more of the patients who need those services to have access to them. There's a big drive from NHS England to look at the investigation of breathlessness and creation of breathlessness pathways. And I'm working with the respiratory and the diagnostics team across the South East to look to see if we can provide a sort of stable breathlessness pathway that allows us to identify high-risk patients who should be pushed more into a heart failure pathway than a respiratory pathway. And obviously that part and parcel of that is the early identification of those heart failure patients. by using methods such as BNP, Echo, ECG. There's obviously some overlap with the other CPIP work streams, specifically with the AF work stream under the remit of the electrophysiologist, and also the valve work stream, which comes under the remit of the interventional surgical work streams. And so we have quite a lot of crossover discussions about how we're going to try and implement some of these objectives going forward. This is our current plan on a page. I apologise for all the words, but fundamentally, it was really interesting to hear Steve's talk and the way in which the NICE guidance can be quite challenging to interpret, and certainly the Esc guidance seems to be clearer, especially from a drug administration perspective, and that's certainly something that I'll be taking forward, having listened to that talk earlier. But very much that the South East CPIP plan does go back to those very sort of basic strategy improvements that need to be considered and put in place and looked at to see whether across the region different services are able to deliver on the key metrics and the ideal pathway processes that need to be put in place for the heart failure patients. So within that, I'm going to focus just a little bit on the work stream. And this is what we're currently working on as a team. And I obviously don't do this on my own. I'm very lucky to be supported by Sally Stanley and also Sanjay Singh, who's one of our GP colleagues in Kent, who some of you may know, who has a long experience of looking after heart failure patients and being involved in pathways within the community. So part of the work stream really initially is to do a gap analysis. It was really interesting to hear Jen's talk and the data that's being collected in the KSS region, because I think that actually there'll be a lot of synergy with what we're trying to do as a Southeast Network group to try and understand where there are gaps in service and where we can support local regional teams to try and improve or change things. Initially, we were considering putting out a network questionnaire, and I'm currently gathering some sort of oversight from that perspective to make sure that we've got the purpose of that questionnaire right, so that we gather the necessary data that's going to be useful for us to work out where there are true gaps or geographical variation. Obviously, we have lots of other data available to us from the National Heart Failure Audit. And I know that there's local audit and governance that is done within the region, and I'm sure we can get feedback information from our colleagues who will be able to tell us whether there are difficulties that they're experiencing, which perhaps have been exacerbated after the pandemic. With that gap analysis, obviously, we will do a data review, and we're very fortunate to have a data team within the Southeast Network group who are able to help us with the number crunching, certainly not my strong point, and hopefully that will generate some interesting data analysis and be able to perhaps to return to meetings like this and show where we feel that there are some interesting areas of good work and perhaps some areas of limitation that need to be supported. It's incredibly important that on a network level we share good practice and learning. So being able to come to meetings like this is incredibly helpful for me, because I get to meet lots of people who are hugely enthusiastic about heart failure and already have done a huge amount of work to improve processes and pathways of patients. And it's really helpful to be able to share that good learning. And having had that discussion recently in the outbreak groups about digital platforms and digital transformation, I think this is certainly something we need to focus on quite significantly for the future, so that we can get the efficiencies that we would need for heart failure patients with these new digital platforms and AI algorithms that might be helpful to us for the future. And then finally, part of what we also do is support funding work streams. So I've recently been involved in an NHSX application, which was very much heart failure associated. I know that the Sussex, Kent-Surrey-Sussex group put a heart failure bid in. Unfortunately, we weren't successful on this occasion, but the Oxford group were successful, and I'll be able to share the successes and what it was that they put forward that allowed them to have access to additional funding for heart failure services in that region. And I know we've recently had some success with a rehab application. So part of the remit of our team is really to support those funding applications and give guidance and advice so that funding can be allocated to appropriate areas where further development of services is required. So really, that's all I want to say. I hope that's been a sort of an overview of what the cardiac network nationally and the regional cardiac network are proposing and trying to do. I'm very happy to take questions. I just put this little sort of picture up, which I stole from a BMJ article about heart failure 360 care, and I think this really does show that heart failure patient is not just about getting the BMP, the ECG, and the heart failure review at the local hospital. There's a huge amount more involved in these patients, and so we're really just scratching the surface with the relative simple pathways that we put in place, because there's a huge amount of other ancillary services that are often involved in the care for these patients. Thanks very much.
Thank you very much, Vicky. It's interesting to see what's happening across the patch and at I guess a slightly higher sort of strategic level, and how much work is going on behind the scenes. We're very grateful that we've got someone like yourself who's taken up the reins to try and work on and improve this. Does anyone have any questions that they would like to ask Vicky? Nothing particularly has gone into the chat box, but any questions? Do you want to pop your hand up or unmute? No, nothing in particular coming. I mean, Vicky, one question would be, I guess, how can we as a group help you in what you're trying to achieve, albeit across a wider geography, but Kent, Surrey and Sussex, how can we help you with the work that you're trying to do?
So I think being invited to meetings like this is incredibly helpful, because I already have a list of names of people I need to contact. So that's a good place to start. But really, if there are funding opportunities or change in systems or things that you feel need perhaps a wider sort of view, then I'm happy to be contacted and can give feedback. It's relatively early days in our structure as a South East Network team, and so we are learning a little bit as we go along. I have had interesting discussions with the Hampshire Isle of Wight team because of the NHS X bids that I put in. So there will be things that come up which allow me access to specialist teams, which then encourages me to sort of reach out to you more to gain information and to make sure we're doing things in the right way. But yeah, so this type of group discussion is really helpful. But if other people have queries, then I'm happy for them to contact me.
Thank you. Did anybody like to ask anything to Vicky, or are we ready to hand over to Sarah? Or is Sarah ready for us to hand over to her? Because she's had quite a challenge in the last half an hour while Vicky's been speaking. Thank you so much, Vicky, for joining us.
So my challenge in the next half an hour, and I don't think it'll take that long, which will be good so you can have a little bit of respite before your next commitment, is to reflect a little bit about today and sort of to talk about next steps. Can I have the next slide, please? So we've had some really fruitful discussions through the breakout sessions, and from my own personal experience, personal sort of perspective from the group I was with, it was just so lovely to be having conversations with colleagues again, and sharing what was going well, what wasn't going well, to hear a lot of common themes, to hear different stuff and get different ideas. So I've very much enjoyed the session I was part of. I've had some key feedback from each of the facilitators, and there's a wealth of information And we will actually put this into a much more meaningful report, and also pick out some key things that we would want to take forward. But just to give you a flavour, and I apologise if this is a bit random because I've got just notes written on my page, but in terms of the patient experience and patient involvement, the things that you were telling us across all of those groups is that patients have really valued their heart failure care over the last 18 months. Particularly, a lot of those services have managed to carry on in some form or other, and initially reverting to very much telephone support, and patients really, really appreciated that. This was a very, very frightening time. There is still a lot of problems in terms of accessing primary care, accessing secondary care, so patients are very much reliant on who they do have contact with, and this also is a problem in itself in terms of the expectation that they have of us, but they very much valued that. Some conversations, the whole system is stretched, and we're part of that very stretched system. Staff are worried about winter, which I think is probably echoed widely. There was within that theme also very much recognition that psychological support for patients is really, really important. But patients have really valued seeing their heart failure nurse again where they've been able to. So there's, as I say, that's just a whistle stop, but there's a wealth of information which we will collate. In terms of the impact of digital technology, again, this was a really interesting conversations, and it was interesting to see similar themes coming out of many of the groups. So the range of interventions have been very, very wide-ranging, to picking up a phone and speaking to patients, and the value that provides rather than nothing else. But also recognising, as we've been able to reinstate some face-to-face reviews, that actually a face-to-face review is actually what some patients absolutely need to be able to assess them appropriately. A lot of services have used home blood pressure monitoring, either asking patients to buy their own machine or supply a machine. There's been concerns about validity of those results, but people thinking about how they cross-reference and get checks in terms of if they're going for a GP review or a pharmacy review, getting a check in those settings as well, and obviously correlating with clinical symptoms. But and the use of scales, very simple technology, and how effective that can be. There was talk about that we just all need to be much more tech savvy. So some patients there's a whole range of patients out there, and we mustn't dismiss an elderly patient because they're more elderly from being tech savvy. And one of the groups talked about gardening groups for the 80s and 90s that they were accessing virtually, and yet we're thinking that they'll struggle with a video consultation. So we do need to think differently, and I think we all need to get much more tech savvy, and I think there's been some reluctance to take on new technology in the midst of the pandemic, when we're all absolutely up to our necks in it, and then have to learn a whole new other skill. There's been some use of video appointments, and some places are using that as their default. That's what they offer, and then telephone if that can't be coped with. So there's a whole sort of mix of that. Some things have been tried in the previously. Docabo as a system, that wasn't useful, and then there was an overall need to think about how we deliver all of this with a different approach. At the moment, we're very reactive. We're just reacting to whatever's being thrown at us, but actually we need to become a little bit more proactive, and we need to be a bit more streamlined and integrate many different pathways the patient may go down because of their comorbid conditions. I've just put onto this slide, and you'll get this sent through to you. NICE have evidence standards for framework for digital health technologies. So they've done a lot of background work So where, if you are concerned about whether something is valid for use, if it's going to be effective, etc., there are some evidence-based standards that allow you to look at what you're thinking about using. So I would urge you to look at that as supporting you in some decision making. And then the final breakout session was you talking about using data to improve care for heart failure patients, and picking up on the chat earlier. And also within the groups, there seems to be a real appetite to develop some community heart failure data. Some nurses have continued to collect the data religiously, but obviously haven't had that data fed back to them. Others say that when we did have data, I didn't really quite know what to do with it. So I think there is something around, if we've got a data set, about how we then support people to use that data appropriately. There was a real desire to make sure there was no duplication of data, and to use data that's already entered into systems if possible, but recognising the huge variety of systems out there that don't then talk to each other. Within the conversations, community pharmacy came up, and as a huge resource out there that's developed over the last couple of years that I think on a day-to-day basis we all recognise, but I think there's perhaps some more integration into our heart failure pathways that we could do. Yes, that sort of really needing to keep pace with the evidence base to identify what data we need to collect. So I think there's a real appetite, but we need to make sure that it's done in a streamlined way and in a very helpful way. People want data to be able to demonstrate the impact on workload. They want to be able to look to see how they can increase staffing and need the data to support those sorts of things. Can I have the next slide, please? So in terms of next steps, we will collate everything that's been discussed today. There's been a huge wealth of information delivered, huge wealth of conversations through the chat, through the breakout groups. We're going to bring all of that together. We'll provide some summary to you of the things that you may not have heard directly. And we will then think about what our work plan is going to be as the collaborative group moving forward. What are the 2 or 3 key things out of everything we've discussed? Do we think we could actually make a difference and help and support and put some work into place that would help you out there? There is an opportunity for anybody out there to get more involved in the collaborative. We've got a steering group, and we would welcome any new members to the steering group. Or we would welcome anybody to offer to get involved if there's a specific piece of work that they'd like to be more involved in. And already we've seen some of the conversations through the chat around the community data. So if you are interested in getting a little bit more involved in just a tiny way or a bigger way, then please do make that clear on your feedback form through the SurveyMonkey. And if there's a specific piece of work that you're interested in, then we would be keen to get you involved. So, you know, the whole value of the collaborative is that we are all in it together, and we are trying to be a strong voice, a collective voice. And I think there's a real strength to that, which I hope we've sort of developed this morning. So please do complete the feedback form on SurveyMonkey, and then you will get your certificate of attendance. We do want to hear how you found today. This is the first time that we've run a virtual sort of collaborative event. We've done some webinars through the thick of COVID, but this is our first sort of trying to get back to our more collaborative sort of event, and we will put more of these on if you feel that this is actually really valuable, and what do you want to hear and talk about within that. And I think one of the things that you heard Alison say earlier, we do want to get a much stronger patient voice into this collaborative. A summary will be circulated, as I've said. I want to say a few thank yous also before I sort of move on to the end bit. So I want to say thank you very much to the speakers today. You've had some fantastic speakers who are really on top of their game and know and have been able to share their work and their thoughts and data and evidence, and I hope that a lot of that will be familiar to you, but a lot of it may well have been new and you've learned from that. I'm also very grateful to all the facilitators who've kindly offered their time to help support the conversations, and as we've said, the breakout groups are a really important part of what the collaborative is about, and because we want to hear what's going on for you and how we can help you. And I also want to thank the British Heart Foundation. Without their support, we would not be able to run a day or half day like this. The background work that particularly Emma and Sarah have done has been outstanding, and really grateful, and they will help us moving forward as well. And I would also like to thank Ben at the AHSN for the IT support, which apart from that little glitch when we all got a bit dizzy moving from room to room, has gone splendidly, so thank you. So finally, I want you to have a little think about something that you'll take away from today, and think about what it might mean in terms of your change in practice. So it may be something very tiny, something quite big. It may be that you want to go and speak to somebody. It may be that you think that you need to really embed a different factor into your practice. So do take the opportunity to think about that, because it's important that you use what you've heard and take it forward. And finally, an opportunity for any questions. We have a few minutes spare, so if anybody's got any questions that they would like to ask, or any points that anybody would like to make about anything that we covered this morning, then please do before we close. So anybody got any questions or comments? There's lots of feedback coming through the chat, so thank you all very much for that. We do appreciate that. Any questions?
So I was just checking if the feedback form had gone into the chat, or how the feedback form was going to go to people, because I wasn't sure where it was.
Ben, are you able to?
Yeah, I can share the Sarah McGillick now.
Thank you so much.
Okay, I think if there's no immediate questions, I think I probably draw the morning to a close, and thank you all very much for coming along today. We've had over 100 participants at the beginning. We're down to just about 75, which I think is fantastic considering the pressures that everybody is under in their day-to-day work. But I hope you've all valued just taking a little bit of time out to reflect, to think, to learn, to share. As I say, we will follow this up with some information for you, but please get in touch if you've got anything that you'd like us to be doing with you. So thank you all very much indeed. Have a good day.